Good morning, ladies and gentlemen. Welcome to the DIM 400 lectures on the musculoskeletal system, with this lecture focusing on infection or osteomyelitis. I'm Dr. LaRue and I'll be giving these lectures. Osteomyelitis, the term used for infection of bone, refers to a combination of osteitis, or infection of the cortex, myelitis, infection of the medulla, and periostitis, infection of the periosteum. In small animals, it's not needed to differentiate between the three of these because infection generally involves all three compartments. If you look at the radiograph on the left, you can see there's exuberant thick brush-like periosteal reaction affecting the ulna in a young animal. We will look at the more typical findings on radiographs as we proceed through the lectures. Osteomyelitis may spread or occur via several routes, and hematogenous is the first one we'll be looking at. Generally, the findings are bilaterally symmetrical, and it occurs most commonly in young animals. The metaphyses and the nutrient foramina are most commonly affected, and we'll discuss that on the next slide. Hematogenous spread may help spread bacteria, fungal, or protozoal underlying causes. So on the image on the left, there's a thick brush-like periosteal reaction with a radiolucent line. It's quite fine, but this radiolucent line between the cortex and the periosteal reaction, and this is due to pus or exudate accumulating between the two. On this radiograph, there's really no appreciable lysis because of all the superimposed new bone. On the image on the right here, both the metaphyses show moth-eaten lysis with a thick brush-like periosteal reaction more proximally. So this slide we covered when we looked at fracture radiology, and I'm just going to emphasize the difference between immature and mature bone blood supply here again. So in the young or immature animal, where the physis is still open, consisting of cartilage, the metaphyses has its own blood supply. And the blood in this area is very sluggish with slow flow. So any bacteria or other infectious agents can localize in this area, and this is the reason for the metaphyseal location of hematogenous osteomyelitis. This is in contrast to the mature animal, which doesn't have its own metaphyseal supply. And in the mature animal, if hematogenous osteomyelitis were to occur, which is quite uncommon, it would enter via the diaphyseal supply. Secondary osteomyelitis is much more common, especially after trauma, such as bite wounds or gunshot wounds or open fractures. The image on the right here shows an example of osteomyelitis post-trauma, and this was a result of a bite wound, and one can see the severe soft tissue swelling present, and we'll come back to this image a little bit later when we discuss osteomyelitis on radiographs more in detail. Osteomyelitis can occur also due to extension from adjacent infected tissues, or it could be iatrogenic from poor surgical technique or fracture complications. Osteomyelitis by extension can cross joints. For example, in the image over here, this was likely a septic arthritis that resulted in lysis of the adjacent bones here in this metacarpophalangeal joint. So there's destruction of the subchondral bone with collapse of the joint, with lysis extending both proximally and distally. There's also a bit of soft tissue swelling present. It's difficult to visualize with this line over here, represents soft tissue swelling, and not to be confused with the metacarpal pad seen over here. Extension from soft tissues can also occur, for example, any infection or an abscess within a muscle or subcut tissue, or also from periodontal infections. Iatrogenic causes, for example, in this case after surgical repair, are luckily quite uncommon, but poor surgical aseptic technique during an open reduction and internal fixation of closed fractures may be a cause of it. So in this case, again, note the severe circumferential thick brush-like periosteal reaction associated with a tibial fracture. This type of periosteal reaction is excessive and it's not typical for callus. So one would not even think that this was just normal callus formation secondary to the fracture. Callus should be much more focal and located at the fracture site normally. Again, here one can see a radiolucent line between the cortex and the periosteal reaction representing exudate. So there are several etiological factors that may result in osteomyelitis. Staphylococcus, Streptococcus, E. coli, and Enterobacter are common bacterial causes. Fungal causes are very uncommon in South Africa, but in other countries, for example, the USA, one might see blastomyces, histoplasma, or coccidioidomycosis, resulting in osteomyelitis. Protozoal causes are also quite uncommon, but these would include hepatozoon and leishmania. Radiation causes are very rare, and implant corrosion are also very rare these days due to the use of much more refined implant material such as stainless steel. In this example here, there's a very weird looking periosteal reaction. It almost looks like a sponge adjacent to the bone with marked soft tissue swelling again. And this is quite typical of fungal osteomyelitis. They tend to be very blastic, so a lot of periosteal reaction and unusual or weird patterns. So on radiographs, the initial finding for osteomyelitis is usually just soft tissue swelling. Remember that there needs to be at least 10 days before bony changes are seen. So radiographs typically lag behind the clinical signs, and it usually takes about 30 to 50% loss of bone before it is seen on a radiograph. The rate of change also depends on the organism virulence and the host defense and resistance. So after about 10 days, one can see permeative lysis resulting in small cortical canals. So on these examples here, it's clear to see all these little punctate lucencies consistent with permeative lysis. So according to our previous classification we discussed at the beginning of the year, this is consistent with an aggressive lesion. So one immediately has to think of something like infection or a neoplasm. One needs to then look at the history, the signalment, and the clinical signs of the patient to help differentiate these two. And then ultimately, in some cases, if radiographs are not that clear, a bone biopsy or culture is needed. So as we go through these lectures, we'll look at a couple of features that can help differentiate osteomyelitis and neoplasia. But for example, like in this case, there might be difficulty where the cases aren't clear, and then a bone biopsy is going to be the gold standard. By about day 20, or day 10, the periosteum will be raised, and this is due to inflammatory debris and pus accumulating beneath the cortex and the periosteum, resulting in it lifting. The type of lysis that we see of the cortex associated with osteomyelitis is called subperiosteal scalloping. So there's eating away of the cortex from underneath the periosteum. So the periosteal reaction is often aggressive. So we're looking at thin or thick brush-like, and it is usually very extensive as well. So here's an example of subperiosteal scalloping, which is very typical of osteomyelitis. If you look carefully at the cortex of the radius over here, there are some defects coming from the periosteal side. Again, in the radius over here as well. The bone is eaten away from the outside or from the periosteal side. This is in contrast to a neoplasm, where the tumor originates within the medulla, and the type of cortical destruction will be coming from the endosteal side, and that'll be called endosteal scalloping, and we'll have a look at that when we cover neoplasia. So from day 20, the thick brush-like periosteal reaction will be present and starting to look more mineralized. The reason why it is at 90 degrees to the cortex is because as the periosteum is lifted very rapidly, this new bone is deposited along the Sharpie's fibers that attach the periosteum to the cortex. Again, in this example that we looked at earlier, there's quite extensive periosteal reaction, thick brush-like, circumferentially around most of the ulna, again with this radiolucent line that we've described as being exudate. So the following slide is just a reminder of what we covered in earlier lectures when we looked at the introduction to radiological interpretation. And it's just revising the different types of periosteal reactions. They demonstrate the different levels of aggression of the lesion according to their appearance. So starting on the left, the solid and the lamellated reactions are the more benign ones. So we're looking at something like a callus of a heel fracture, or a mature subperiosteal hematoma, or even healed osteomyelitis. Moving over to the right, the thick and thin brush-like reactions are moderately aggressive, and here we should think about things like osteomyelitis, Mari's disease secondary to Spirocirca lupi, or possibly neoplasia. And then moving even more to the right, of the right of the scale, we look at sunburst and amorphous new bone, and this is highly suggestive of neoplasia, and it's the most aggressive type of bone or periosteal reaction that we can see. So I have already mentioned this radiolucent line that separates the periosteal reaction from the cortex, and this is one of the important features that we use to distinguish osteomyelitis from neoplasia. It is just consistent with that layer of exudate, which a neoplasm won't have. Also, in this case, notice the extensive moth-eaten lysis affecting the radius. Also, what this slide shows is multiple bones being affected. So the ulna also has a periosteal reaction associated with it, additionally to the radius. So this is more common for osteomyelitis, to be able to affect multiple bones rather than our common bony neoplasms. So by day 30, a sequestrum forms, and this is an important concept to understand. A sequestrum is a dead fragment of bone, and it looks quite sclerotic and more radio-opaque than normal cortical bone. It tends to be sharply marginated, and the reason for its appearance is because it's inert. It has no blood supply left, so it's dehydrated, and that's why it's more sclerotic. So here are two examples of sequestrum formation. On the left, it's a dorsopalmar view of the metacarpus 3 and 4 of a bovine. There's two very opaque structures consistent with the sequestra present. If you compare their opacity to the normal cortex down here, you can see that they're much more opaque. And there's also a radiolucent zone surrounding each one, and that is consistent with purulent material or exudate. There's also quite a lot of thick brush-like periosteal reaction circumferentially around the bone, resulting in the whole area having a slightly sclerotic appearance. On the right, it's a mediolateral view of the antebrachium of the canine, and it's a similar finding with the arrow pointing to the sequestrum, or the dead piece of bone, which is surrounded by a radiolucent zone of exudate, and then there's a cortical defect cranially to that. And this is most likely as a result of osteomyelitis secondary to focal trauma, like a bite wound. So from day 40 on, the osteomyelitis becomes very chronic. It may cross joints, and it may affect adjacent bones. For example, in this carpal joint, the small carpal bones show quite a lot of moth-eaten lysis. And there's another two important concepts that we must look at, and that's the formation of an involucrum or a cloaca, and I'll discuss that on the next slide. So an involucrum is just a bony sleeve that forms around the sequestrum by the periosteal reaction. It can be focal or involve the whole diaphysis, so it can be quite extensive, or it may be a thin layer. For example, in the schematic here, it's a thin periosteal reaction, or it might be quite thick. So in this region over here, there's a radiolucent zone within the femur, within, it's a bit difficult to define here, but there appears to be a sequestrum, and then over here is the bony sleeve or the involucrum formed by the periosteal reaction. The cloaca is a defect in the involucrum, and this results in a draining tract, and it allows the pus and the debris to escape. Sometimes it can even exit the skin surface, and it tends to have round and smooth margins, and in some cases, the dead piece of bone or the sequestrum might even be expelled through it. Here's an example of a malunion fracture where there's a linear sequestrum present and a large radiolucent pocket of exudate. If you look carefully, it almost looks like there wants to be a cloaca forming in this area over here, and then this will be the involucrum, which is the periosteal reaction that has formed over it. Here are another two examples of cloaca formation. On the image on the left, the arrow points to the cloaca. The bone, the periosteal reaction that is crossing in this area is the involucrum, and then there's this poorly defined radiolucent area of exudate. In this case, it's not clear that there is a sequestrum. I think the little pointer might be pointing at it, but what would be a good idea in this case is to take an orthogonal view. What one can also see on this radiograph is the cranial periosteal reaction is an onion skin or lamellated periosteal reaction, and that indicates a mildly aggressive to almost non-aggressive periosteal reaction, which is consistent with an osteomyelitis that is healed. So there's an active site caudally, but the cranial site which was affected has now healed. On the right, again, there's extensive thick brush-like periosteal reaction affecting the ulna, and there's a defect caudally with and that's the cloaca connecting to a little radiolucent pocket here. Again, a sequestrum is not seen on this. It might just be too small, or one would need an orthogonal view. Here's another example of complications of fracture repair. There's a radiolucent zone around the whole pin, and this could be either due to motion of the pin or infection around the pin. It might be a little bit of both. There's a bit of rhino horn callus sticking out the back here. There's a linear sclerotic piece of bone here, which might be dystrophic mineralization of a hematoma. And then there's a large radiolucent zone over here with a sequestrum on the inside. Cranially, there's involucrum formation by the periosteal reaction, and there's a defect consistent with the cloaca. So this might lead to a draining tract onto the skin. And then lastly, this is just a very nice example showing those three concepts, the involucrum being the periosteal reaction, the cloaca being the defect in the periosteal reaction, and the sequestrum being the dead piece of bone that is sitting within this radiolucent pocket of exudate, which will drain through the cloaca. Another note on periosteal reactions, their activity can be classified based on the sharpness of the margins. So an active lesion will have indistinct margins, whereas an inactive lesion will have very well-defined margins. And I've got some examples on the next slide. So in this case, the periosteal reaction is quite crisp, and it's easy to see its margins, and this is consistent with an inactive periosteal reaction. In this case, especially if you look craniodistally over the radius, the periosteal reaction margins are very indistinct, and it's not really clear where their margins are. That is consistent with an active periosteal reaction, whereas some of the bone more proximally is much more mature. So this is a nice slide that shows the contrast between the two. Here's another example of a bacterial osteomyelitis. This patient had a fracture. You can see there's the fracture up there. And here is a solid immature periosteal reaction that is circumferentially around the diaphysis of the femur. There also is a little bit of rhino horn callus here already, or due to periosteal stripping. And then when the radiograph is repeated 3 weeks later, you can see that the fracture has been repaired, and the periosteal reaction now looks more thick brush-like, but it is definitely much more mature. The margins are quite smooth, and here the rhino horn callus is much more obvious and also much more mineralized. So this is coming back to the previous example that we had. Focal osteomyelitis tends to be much more localized. There is a sclerotic border often involved. So if you look at this bone over here, there's quite a wide white zone or sclerotic zone around the area that's affected, and that's because the bone is trying to wall off the infection. Periosteal reaction tends to be much more mild. For example, here's a little bit of irregular periosteal reaction present, but it's really not much. And in this case, it's a little small sequestrum that has formed. The infection generally doesn't tend to spread up and down the bone like the hematogenous ones do. Now, with healing osteomyelitis, the lysis is replaced by new bone. The bone sequestra become more irregular and much smaller, and then the periosteal reactions regress, and they become more solid and less aggressive, smoother, and then they recede. So that scale that I had earlier, they will move towards the left on the scale. Right, so the last slide just gives a couple of factors that will help give some more information on osteomyelitis, and later on we will be comparing osteomyelitis to neoplasia, so this will become important. Osteomyelitis can affect any age of animal, although hematogenous osteomyelitis will tend to be in younger animals. Any breed can be affected. The lesions can be either polyostotic, so multiple bones, and that tends to be more hematogenous, or monostotic, one bone, which is more likely due to trauma. It can cross the joints and affect adjacent bones, which is important. A lot of neoplasms don't. The location tends to be metaphyseal in the young animal because of that sluggish blood flow, or diaphyseal, because that's where the main blood supply comes in. For traumatic osteomyelitis, the location is not that important because bite wounds or fractures can really occur anywhere. The periosteal reaction will be aggressive, extensive, and palisading. Palisading is just another word for thick brush-like. And lysis will be moth-eaten to permeative, so also aggressive. The transition zone might be well defined as the body tries to wall it off. And the cortical scalloping, as I've discussed, is subperiosteal, so from outside of the cortex. If we look at bone destruction versus production, osteomyelitis tends to be more productive, especially fungal osteomyelitis. The rate of change tends to be slow on serial radiographs, and then Sequestrum, Cloaca, and Involucrum formation is typical for osteomyelitis, whereas it doesn't occur with neoplasia. All right, so that is the end of the lecture on osteomyelitis, and the next lecture will follow on with bone neoplasia.